This is the first lecture in the Chapter 8, Fluids and Electrolytes. We're going to begin with just some basic terminology. It's my hope that this terminology is really all review for you, so I'm going fairly quickly through this. Electrolytes simply refer to substances that dissociate in solution to form ions. So the ions are basically particles that have an electrical charge. Let me get even more specific in saying cations are those that have positive charges. The cations we're going to be looking at in our Fluids and Electrolytes chapter are sodium, which has a single charge, potassium, a single charge, calcium is a 2+, magnesium has a 2+, and we will also be looking at a hydrogen, although we'll look at that more in terms of pH than in regular electrolyte functions. Anions are negatively charged. We'll be looking at chloride, which has a single negative charge, phosphate, which has a 3 negative charge, and bicarbonate, which has a single negative charge. A colloid is a substance that won't dissolve in fluids or water, and it plays the role of solute when we talk about creating osmotic pressure. So an example of a colloid we'll be looking at are the blood proteins, albumin in particular. Diffusion is a passive process in which particles move along a concentration gradient from higher to lower concentrations till it reaches homeostasis or an isotonic condition. Osmosis is the movement of water across a semi-permeable membrane. I think that's the classic definition we've heard for years. In the case of what we're dealing with here, we're going to be looking at cell membranes as our semi-permeable membrane. Osmotic pressure is a force that drives the movement of water across the membrane. So pressure is generated by the solute that's present. It's a pulling pressure. The solute pulls the water towards it. So osmotic pressure, again, is a force that drives the movement of water across the membrane. Since pure water has no solute, it has no osmotic pressure, but as soon as you add a solute such as sodium or sodium chloride, the solution will now have an osmotic pressure as that salt increases the pressure, the pull of fluid. Now we have terms osmolarity and osmolality. Both are a measure of the numbers of particles in solution, but osmolarity is per liter and is generally used in referring to fluids outside the body, and osmolality is per kilogram and is generally used when referring to fluids inside of the body. However, since 1 liter of water weighs 1 kilogram, the terms are very interchangeable, and you'll see as I talk both in lecture and in class that osmolarity, osmolality are really used very interchangeably. They have basically the same meaning, that same measure of the number of particles in solution. Isotonic solutions are equal. Hypotonic solution has less solute than, for instance, the cell. So therefore, if we talk about a cell, and probably that's what we need to be thinking about here in terms of the definitions. An isotonic solution means the concentration versus fluid inside and outside the cell are equal. So from the interstitial fluid versus the cell. In a hypotonic solution, our solution has less solute, or the interstitial fluid has less solute than the cell. Therefore, water moves into the cell, causing the cell to lyse. So in a hypotonic solution, you have more solute inside the cell than outside the cell. Water moves in. In a hypertonic solution, the solution or interstitial fluid has more solute than the cell, and water will move out of the cell, causing the cell to shrink or crenate. Again, intracellular fluid are all the fluid inside the cells. It comprises about 2/3 of our body water. Unfortunately, we don't get to measure intracellular fluid very easily. It's not like we can stick a needle inside the cell and say, oh, let's take a look at what's going on clinically and treat our patients. So instead, we're going to basically be looking at extracellular fluids. Now, that's all of the fluids outside the cell. So it includes interstitial spaces, it includes blood vessels. The extracellular fluids include what we would call transcellular fluids, fluids in the peritoneal, pleural, and pericardial cavities in joint spaces. It includes saliva, urine, sweat, tears, mucus, bile, and I can go on. If you can think of a fluid inside the body that isn't inside a cell, Every other fluid, most of the things we can draw from and test from, cerebral spinal fluids, lymph fluid, even semen, synovial fluid, those are all extracellular fluids. So in terms of body weight, intracellular fluid makes up about 40% of the body weight, so it's nearly half, and the rest of the fluids, the extracellular and interstitial fluids, make up the rest of the body weight. It's important to note that our interstitial fluids are not actually in pure liquid form, but they're rather in a gel form. It's fluid that's composed of large quantities of mucopolysaccharides. There's collagen fibers. It allows for that interstitial fluid to not be so squishy or watery like. So think about it, if all of the extracellular fluid in that, or I should say all the interstitial fluid was truly watery like blood, we would be, the consistency of the human body would be entirely different. So it's really in a gel form. The electrolytes we're going to be looking at throughout this chapter are listed here. What I want you to recognize is whether the concentration of that particular electrolyte is greater in the extracellular or the intracellular fluid. So ECF versus ICF. I do not require that you know the specific numbers, rather simply that there is more extracellular or more intracellular. So for instance, sodium is highly concentrated in the extracellular fluid, much smaller amounts intracellularly, whereas potassium is just the opposite, and so forth. So I do not require you at any point in this course to know these particular numbers exactly. I will provide them for you, mainly because you will come across lab work from different labs and different facilities you may encounter in which the measurements may vary in terms of what is considered normal values. So these are the normal values your book uses, and everything is worked off of those, but clinically you may encounter some different values, just different units of measure. So for that reason, I do not ask my students to memorize them. I will always provide normal values, but you must know whether the sodium is more commonly found extracellularly or intracellularly in terms of the normal stuff. So that's what you need to know. It's important, and you also need to know if it's large amounts, moderate amounts, or small amounts. And your textbook, actually read it, because it actually mentions that right in the reading, right near where this chart is found. It actually addresses sodium has a very large amount in the extracellular fluid, very small amounts intracellularly, vice versa, but some are more moderate levels if you look at the actual numbers here. Be sure you're reading that in the book. Fluid exchange is an important concept. In order to understand the rest of the functions of electrolytes, we have to understand how fluids work in the body. These concepts here, what you see listed here, are actually review from A&P 2. In fact, this image that's down here is the picture from the A&P textbook that we use here at the college. So if you've taken A&P 2 somewhere else, this image may not be so familiar to you. If you've taken it here, I am hoping you've spent a fair amount of time with it and you understand the concepts that are listed here. I will go over this briefly. If you are struggling with this is something I would encourage you to get some tutoring on, or see me independently and we can go through this. I'm not going to take a lot of this lecture to go through it because the processes are actually review from A&P. But what we're basically talking about is the two categories of forces of pressure that exist in blood as it moves through the capillary beds. Remember, capillary beds are single-walled vessels, so these forces are moving to push fluids, ions, nutrients, and oxygen all diffuse in and out of these capillaries to hit the tissues of the body. We have a lymph vessel right here in green that is actually in most of the areas of the body where you find capillaries. So the two categories of forces are hydrostatic pressures and osmotic pressures. As I mentioned earlier, osmotic pressures are pull pressures. So these forces are generated by solutes, the level of solutes that exist that pull fluid towards it. Hydrostatic pressures are push pressures. They're based upon the pumping of the heart, that force that comes from the pumping of the heart, and the total volume of the blood pushing against the walls of the vessels. So in other words, if blood volume is higher, we already know blood pressure is higher. So the higher that pressure is, that blood volume is, or blood pressure, it's pushing against the walls of the vessel. That push moves fluid out. So what you have really happening is basically four pressures, two categories. You have what we would call capillary hydrostatic or filtration pressure. That is the pressure that's being pushed through. It's often referred to in our image here as blood hydrostatic pressure. So capillary or blood hydrostatic pressure is pushing fluid out. Now, red blood cells should stay in here. Some of the larger proteins should remain within the blood, but ions, smaller proteins, and again, depends on the capillary. Some capillaries are fenestrated or sinusoids, and larger substances move out. But for the most part, we're just seeing ions, some small nutrients, things like glucose are moving to the cells, and obviously the oxygen is also being pushed out, but the red blood cells are remaining in. So that blood or capillary hydrostatic filtration pressure is a push out. Interstitial hydrostatic pressure is actually a push in. So in this one we have interstitial fluid hydrostatic pressure here. It's generated by the amount of fluid that exists here in this interstitial space. Assuming all things are normal and healthy, the interstitial fluid osmotic pressure is generally at zero. In other words, there is no push back in. There's not enough of a volume. There's no force here. There's nothing pumping the way blood was being pumped through here. And so this pressure that exists in the fluid in this space is not really valid right now for a normal function. If in fact, however, edema forms and we have excess fluid in this area, which is really the imbalance we're dealing with fluids is in edema. If there's more fluid in this area, this then can have a weight or a force that pushes some fluid back in. Likewise, we have the two colloid osmotic pressures. Those colloids are basically, especially within the blood, are generated by albumin, that plasma protein I mentioned earlier. Osmotic pressure pulls the fluids back in. So at the same time that you have a force pushing fluid out, you have a force pulling it back in, so that the two somewhat balance each other. So we have some values here. I do not require that you have any of these values memorized, but you need to understand the concept. As the blood is being pushed out by the force of the volume and pressure of the heart pumping, you will also have albumin and other solutes within the blood pulling the fluid back in. Now, at the capillary end, the force is very large. Or I'm sorry, yes, at the capillary end, it's very large. At the venous end, I should maybe say arterial end versus venous. At the arterial end, you actually have a greater force. Our capillary pictured here looks like a straight line single vessel. I hope that you recognize that capillary beds are actually more like spider webs of networks of vessels, and it isn't necessarily a single vessel, but there's many and multiple branches that actually interact here. And so as the blood is pushing through and the branching goes on, what you see is the pressure start to drop. You'll notice in our picture here, the BHP is the blood or capillary hydrostatic pressure. It's 35 at the arterial end, and it's only 16 rather at the venous end. So as the blood moves through the capillary bed, the pressures drop. So throughout the course of the entire vessel, pressures change from hydrostatic pressure from 35 to 16, but your blood colloid osmotic pressure, you see, is unchanged because those solutes should remain the same throughout the entire capillary bed. So again, you've got these forces of push and pull. Now there is an interstitial colloid osmotic pressure, and you see in our image right here it has a value of 1. The substances that are out here, maybe a few of the albumin, they're fairly small, make it leak out of the capillaries. So you may have some albumin that's doing a little pulling out here. There's some solute. There may be some sodium out here. Most of the sodium hangs out right near the cells, but there is some here in this area as well, and they can have a little bit of a pull force. So you do have some interstitial fluid osmotic pressure possibly pulling out a little bit. Now, Stirling's hypothesis of filtration is really the theory that encompasses all of this. It basically says in order for filtration to occur, it is based upon the mathematical fact that the forces that favor filtration must be greater than the forces that oppose it. So in other words, in order for things to move out, there must be a greater push out than a pull in order for there to be filtration. And that's really what we're looking at here. This is movement out and then movement back in. And the forces, if they're greater out, fluid will filter out. But if the forces are greater to pull it back in, then it won't filter out of the blood vessel. Now, these matter Because when we look at edema, edema is related to something going wrong with these forces. Blood pressure gets too high. Capillary osmotic pressure is affected by lack of albumin. The liver stops making that plasma protein. Something accumulates out here. Or you see we have a lymph vessel here. One of the functions of lymph vessels is going to be to pick up any extra fluid that doesn't make it back in. And so lymph damage can interfere with our ability to pick up the excess fluid. And we'll look at that in just a second. So let's talk for a second about what edema is. It's a buildup of interstitial fluids. Usually you have visible edema when your fluid levels get to 2.5 liters or greater. It's a kind of an arbitrary number. It's not something you easily easily measure. Generalized edema is due to an increase in vascular volume, whereas localized edema is what really occurs more in allergic or inflammatory conditions. So generalized edema can be overall body edema. Localized maybe in one area or another. Now here's what we say is our 4 primary causes for edema. Increase in capillary hydrostatic filtration pressure. This is an increase in blood pressure. So this is one of the things that happen when people have high blood pressure. They may get edema because that force, if I back up here for a second, the force, of the fluid moving out pushes too much fluid out than what can be pulled back in. The second cause is a decrease in capillary colloid osmotic pressure. That's that pulling back in pressure. I said that's albumin. Albumin's made in the liver. If we have liver disease, for instance, sometimes kidney disease can be involved here. The kidneys can be filtering the blood and pull out too much albumin, so there isn't enough in the blood, or the liver stops making it because of other issues that the liver is having. Lack of a solute means lack of osmotic pressure. We lose this pull back in, and we have fluid that's being lost. There can also be an increase in capillary permeability, and hopefully that concept is very familiar to you, having just done inflammation. So histamine, even some prostaglandins, other chemical mediators are involved in changing capillary permeability in inflammatory responses. So there's an increase in capillary permeability in inflammation. We want the substances to get to the areas of damage in our body. That's what inflammation's about. But what that will do, will lead to more fluid in this interstitial space. Fluid will move out. And then lymphatic obstruction. I mentioned that before. You have a lymph vessel here that's picking up any excess fluid and putting it back into circulation. Well, if there's damage to lymph vessels, if there's tumors and lymph nodes, if there's a surgical removal of nodes and vessels, you don't have this protection, and edema can form because you're not able to pick up the excess fluid that naturally occurs there. Under normal circumstances, even when a person is healthy, there will be excess fluid. The push out is just a little bit greater than the pull in, and we expect the lymph vessels to pick up that excess and keep us in balance and not have edema. Remove that, and slowly fluid starts to accumulate here, and there's no place for it to go, and edema can form and become chronic. So those are your 4 primary causes of edema. In other words, the big categories of things. Really, all edema in some way or other can be linked to one of these issues. Now, the manifestations of edema, and your book talks about these as well. The biggest manifestation that I want you to know about is the fact that when fluid is in this inner, if I go back to our picture again, sorry, I keep bouncing back and forth, I apologize. When I get into this area right here, here's our tissues, here's our capillary. We expect things to diffuse from here, oxygen diffusing it from the arterial blood to the tissues, electrolytes, nutrients, glucose, they all have to get to the tissue. Likewise, waste products, carbon dioxide, they have to diffuse out of the cells and back into the, we'd say more the arterial end, to go back through the lungs for exhaling carbon dioxide, for the kidneys to be filtered as waste. So this is the space we normally have to deal with. When there's edema, that space doesn't look like this. It's 2, 3, 4 times the distance. With such an increase in distance because of all this excess fluid pushing everything back and forth out of the way, you cannot get your substances, your oxygens or your carbon dioxides where they need to go. The diffusion distance increases, and therefore your tissues do not get their nutrients, waste accumulates in this area, and cells can become damaged and die. So the biggest manifestation of edema is the fact that you have this increased diffusion distance, and tissues, cells, are starving for nutrients and accumulating wastes. That's a huge problem with edema, and that's why with edema you can eventually see necrosis develop. Now, not every bit of edema automatically goes there, and it's not to the point that as soon as edema is there you're thinking cells are dying. But over time this can be, and especially in extreme cases of edema, this is a real problem. Now, there are other manifestations of edema that are more linked to things like discomfort. Now, clothes can be tight, there can be restriction, there can be pain and pressure, all of which can be very uncomfortable. Certainly there are areas that the edema can be very severe. If it's in the brain and you have cerebral edema, that can be very damaging to nerve cells, that can lead to many other manifestations. Pulmonary edema interferes with gas exchange. That's really a problem. There can be inflammation that occurs in the area around the larynx that can affect airflow, and it can affect swallowing food, getting into the digestive system, and so forth. There's always going to be some weight gain associated with large amounts of edema, and again, the nutrient and even the healing process, because again we need oxygen delivery, hormone delivery, all of those things are interfered with when that diffusion distance increases. In terms of types of edema, so we had causes, then we say, okay, well, how do we categorize what we actually see now? Well, dependent edema simply refers to edema that's linked really to issues of gravity more than anything else. We see it in the ankles and the legs. So a person who's in bed rest may be in the sacral region. So dependent edema usually linked to high blood pressure issues or capillary hydrostatic issues. But again, gravity is important there. Pitting edema is where the fluid accumulates in the interstitial space. You can press your thumb or finger into it and see an indentation. There's pictures in your textbook of this. And then non-pitting edema is something we've already really looked at when we talked about mixed edema in the thyroid, in hypothyroidism. It's usually accumulations of proteins, possibly even plasma proteins, accumulating in the interstitial space. They tend to coagulate. This tissue feels very firm, hard to the touch. It may even be discolored. Then we have what we refer to as third space accumulations. Third space accumulations are when fluid starts to accumulate in what we would call the transcellular spaces. And your major transcellular spaces are in the pleural cavity, the pericardial cavity, and ascites is in the peritoneal cavity. So here's our peritoneal cavity, and it's filling with fluid. So if you've ever seen someone with ascites, it is most commonly linked to someone who has liver problems. You can see it in burn victims, malnourished patients because of liver disease associated with malnourishment. Some pancreatic disease can result in this. The key to all of these, this would be fluid around, not in, but around the lungs, fluid around the heart. And it can be very problematic, and we'll talk more about pericardial effusion in the cardiovascular chapter, and pleural effusion in the respiratory chapter. But the big deal here is not only do we have these fluids accumulating around crucial areas of the body, and in the GI tract, this picture here, I think you should get a sense that that patient is in great discomfort with all of this fluid. But the other issue is that all that fluid should be in the blood, and it's not in the blood. It's usually because of lack of plasma proteins, and the fluids are being pushed out of the blood vessels. So the patient actually appears dehydrated. They have all this excess fluid, but their blood vessels are lacking in sufficient fluid. So dehydration is a huge problem. There's actually a significant decrease in blood volume, which has profound effects on the cardiovascular function. A little bit more about water balance. The amount of water in the body is directly related to age. Over time, it will decline. So the older you are, the less fluid there is in the body. Adipose tissue takes up the space of water. So one of the complications of obesity is dehydration. The more rapid your metabolic rate, the more fluid intake that you need, the more you have at risk of dehydration. Infants have extremely high dehydration risks because they have very high metabolic rates. And again, we're talking young newborn in the first 3 months of life in particular. They do not have fully developed kidneys, so they lose a lot more water with their urination. Their stools tend to be soft and watery, so fluid is lost there. And when you look at their total surface area to their weight, just the perspiration that occurs naturally in humans will be far greater. And if they cry, there can be fluid loss with a lot of the crying. So infants are really high risk of dehydration, have to be watched very closely. In terms of fluid losses, the term insensible losses means things like sweat or respiration, things we really cannot measure. Doesn't mean we can't test it. We can swab for some of those things, but we really cannot test the amount of fluid you lose fluid in the air when you speak. Can't measure that. Measurable losses, though, are things that we do look at. For instance, we can obviously test urine. We expect on average to lose about 1 to 2 liters per day. Bowel activity can be watery, and we can test and measure stools. If there's vomiting and some hemorrhaging, some blood loss can be measured. So how does our body regulate water and sodium? So first we have thirst. Lots of different things make us thirsty. Foods can make us thirsty. Speaking can make you thirsty. There's a variety of different things that can lead to thirst. We have some categories of thirst. I do want you to be familiar with these terms. So someone has hypodipsia, they have the inability to sense thirst. So this is particularly prevalent in the elderly. So it's not that they have an unusual thirst, they cannot sense it at all in many cases. So they don't drink enough because they don't recognize that they're thirsty. So hypodipsia is the inability to sense thirst. Polydipsia means excessive thirst, and it isn't necessarily abnormal. If you are dehydrated, you should have polydipsia. You should be thirsty. So that's not always abnormal. We can put them into 3 categories. So symptomatic thirst is linked to loss of body fluids. It's what we would expect to have if we've had diarrhea, vomiting. There are conditions, both diabetes mellitus and diabetes insipidus, and we'll talk about diabetes insipidus in just a moment. Things that are just causing dehydration, normally that's symptomatic thirst. It's normal thirst. But then you have inappropriate or false thirst. This is a thirst sensation that continues despite being adequately hydrated. So you can feel thirsty when you're not actually thirsty. This is linked to things like chronic kidney disease, congestive heart failure, and sometimes medications can make you thirsty. Excessive speaking, you may be drinking and drinking, your mouth is dry from the speaking, but in fact your fluid volume is in fact still normal in the body. And then there's compulsive water drinking, or what we call psychogenic polydipsia. This is usually related to some sort of psychiatric disorder. It's often associated with schizophrenia. It's relatively rare, but you can see someone who's compulsively drinking, and it's not linked to anything physiological. We have some conditions that cause us to drink. Diabetes insipidus can actually cause you to drink, and thirst can be truly thirst. A person can truly be dehydrating or have true thirst. Now, thirst, or that craving to drink, is regulated by osmoreceptors in the hypothalamus. So it's that area of the brain. There's a thirst center that's very sensitive to any changes in fluid volume. Less than 0.5% of a decline in our fluid volume in the body will trigger a sense of thirst. You also have some baroreceptors that are measuring blood volume. They are found within the arterioles, vessels, and in the atria of the heart, sensing changes in blood volume and blood pressure through baroreceptors. So you have osmoreceptors in the hypothalamus, and you have baroreceptors in the heart and blood vessels. In addition, the sympathetic nervous system can respond to changes in arterial pressure and blood volume. It actually can affect the afferent arterioles of the kidneys to regulate glomerular filtration and actually help us to retain more fluid, retain more sodium as necessary. So the sympathetic nervous system works in response to actions at the kidney to stimulate the RAA pathway. This is the RAA pathway. This too is a picture from the AMP2 book. If the RAA pathway is something that you are not familiar with, the renin-angiotensin-aldosterone pathway, this is something that I don't put this diagram on the exams or quizzes and expect you to be able to label the diagram, but you need to understand all of the components that are involved in the process of secretion of both angiotensin II and aldosterone. Both of them function very crucially in maintaining blood pressure and blood volume in the body. Aldosterone is your primary regulator for sodium and potassium and also regulates hydrogen. So you need to know about this hormone. Angiotensin II is a very powerful vasoconstrictor and it stimulates the adrenal cortex to make aldosterone. So if you're looking at this and saying, wow, never seen this, don't know anything about this process, another thing you want to get with a tutor with, get with me to go to your AMP books. Please come to an understanding of this process, understanding of these two really important hormones. So that's really sympathetic nervous system working with the kidneys, working with the body, working with formation of aldosterone and angiotensin II. So it's a component of our regulation. And then ADH, antidiuretic hormone, it's made in the hypothalamus and secreted from the posterior pituitary gland. ADH is all about retention of water. It targets the kidneys to keep water. There are a couple of diseases that are related to abnormal aldosterone levels. It's Addison's and Cushing's. And then there are two diseases or conditions that are related to abnormal ADH, also sometimes called vasopressin. They are diabetes insipidus and SIADH, which stands for Syndrome of Inappropriate ADH, or antidiuretic hormone. I do need you to be familiar with all four of these conditions because they do link to abnormal conditions with both sodium, potassium levels in the body, fluid levels in the body. So again, there's handouts that are actually also posted on the Moodle page for the course to take a look at those as well, to be familiar with whether we are looking at excess amounts of aldosterone or not enough aldosterone. And again, remembering that aldosterone, part of that RAA pathway, its job is to retain sodium and excrete potassium, and it also works to excrete hydrogen ions. So it's the primary regulator for sodium. Water follows sodium because of its osmotic properties, so things that go wrong with aldosterone affect blood volume and blood pressure. Likewise, ADH, its main function is to target the kidneys to retain water. So diabetes insipidus, which is in no way related to the diabetes mellitus, it's not about glucose at all, but diabetes insipidus is when a person loses too much water because of a problem with ADH. Really important to understand that with diabetes insipidus, there's two forms. Neurogenic is a problem with making ADH somewhere in the hypothalamus, or something with the posterior pituitary. You're not making it and releasing it into the body. Nephrogenic diabetes insipidus is when the receptors in the kidney tubules don't respond to ADH. That's where the target is, that's where the receptors are, and suddenly something's blocking those receptors or something's damaged those receptors in the kidney. There's kidney disease, for instance, can lead to nephrogenic diabetes insipidus. The body's making ADH just fine, but the kidneys aren't responding to it. Really important, because if my fluid balance is off, as you'll see in the next lecture, that's going to strongly influence sodium balance. And sodium is a crucial ion for a number of different functions in the body. So take some time, read through, and become familiar with all of these conditions.